Welcome, ladies and gentlemen. This is the Public Safety and Justice Affairs Committee meeting this Tuesday, March 3rd, 14 days before the great holiday of St. Patrick's Day. If I don't see you, happy St. Patrick's Day. Roll call, please.
Calling the roll, Mr. Gallagher.
Here.
Ms. Baker. Here. Mr. Tuma.
Here.
Mr. Brady.
Here.
Ms. Conwell. Present. We have a quorum. I would like the record to reflect that Councilman Miller is also in attendance.
Welcome, Mr. Miller. Public comment?
No, Mr. Chair, no one is signed in.
Okay. In your packet, we have the meetings of February 18th. If they're in order, I'll accept the motion and a second.
So moved. Second.
All in favor?
Aye.
Against? Thank you. Nothing referred to committee. We're going to have a discussion today on the community's plans around that are around the COVID-19 coronavirus that is in the news, and we think it important on the county side to find out what we're dealing with, what we will be dealing with. I know it's flu season, and that is foremost right now. But to allay any fears of the public, I think it's important to as we're all washing our hands, to get information as much as possible, as soon as possible out. So who we have here today, we're going to have the Cuyahoga County Board of Health. That's Terry Allen, the commissioner. Then up we'll have our County Public Safety and Services Director, Alex Pelham, Management Manager of Public Safety and Justice Services, Kevin Fries. Metro Health, we have Dr. Amy Ray and Dr. Watts. Dr. Watts, thank you, ladies, for being here. And finally, if necessary, we have the Law Department for any concerns or questions. Dr. Bruner, I see, also is here. She's the medical director at the jail, which is an important part of this discussion either today or in 2 weeks. So we'll see where that takes us. Mr. Allen, please.
Thank you, Mr. Chairman, and members of the committee for the opportunity to come and talk with you today. So we've been hard at work with our partners from Metro Health and other hospital systems, from County Office of Emergency Services, from a whole range of community partners around education and getting our hands around this quickly evolving situation. I would assure you at the start that in our department, in the community, we have folks that have experience with a whole range of emergencies that go back 20 years, in some cases much more, to sort of post 9/11 anthrax, smallpox, H1N1 influenza in 2009, the Ebola response in 2014, and now dealing with this emerging COVID-19 challenge. So there's a lot of experience, and it helps so you're not passing cards out in the middle of starting a conversation. So we feel good that we've got the people in place to respond. So I'm going to provide an overview. I would also say we have two eminent folks from Metro infectious disease physicians that are here if you have specific clinical questions that are much more qualified to answer those questions should they arise during the presentation, Drs. Ray and Dr. Watts. So here's just a quick background on the beginning of things, such as we know them. At the end of December, as well reported in the media, there was announced cases that were a cluster of cases identified in Wuhan, China, and Hubei province that occurred at the end of December. The thinking is that there was exposure at an animal market. Animal commerce is quite common in many parts of China, and there can be, in some circumstances, mixing of human and animal viruses, bats, chickens, things of those nature. So that's the thought process. Isolated the actual virus as a new virus in January 7th, and then we started to see cases because of certainly commerce, cases around beginning to be exported. Entry screens that began in the middle of January, United States airports. We had actually, the CDC developed an initial test, and that'll be sort of an ongoing process that we'll talk about related to testing. That's still very much a work in progress. First case in the U.S. in the 21st of January, and then the first spread at the time at the end of January between actually spouses January 30th. And then shortly after, in very early February, there was an announcement around travel restrictions and also an announcement around those coming from Wuhan, Hubei province, which was the epicenter, that there would be actual quarantine occurring through 11 airports where they would exit and be funneled to specifically be quarantined for 14 days, which is the period in question of concern. And so then also people that were coming from China but outside of Hubei specifically would then self-monitor if they had symptoms. They'd be self-monitoring and basically self-quarantining in their houses. And that's been happening around the country. Certainly here in Ohio, we've had people do that, and we'll talk a little bit about it. And then self-reporting back to the health departments should they exhibit symptoms. So we know that the coronavirus is part of a large family of viruses. There are several coronaviruses that are responsible for cold-type symptoms that we deal with all the time. Species of animals involved with coronavirus, different viruses, and can involve a range of mammals, as you see here. We know that SARS has been associated with an animal called palm civets, and we know that MERS, which is the Middle Eastern Respiratory Syndrome associated with camels. And so these viruses have surfaced from different times over the years, and so we've seen a few coronaviruses circulate. First detected in Wuhan, as we mentioned. Fever, cough, shortness of breath are the hallmark of symptoms. And as mentioned earlier, we are still in flu season. This year we've seen 16 flu fatalities in this county. We've seen over 3,500 folks go to the ED for flu-related concerns, and we've had 1,500 hospital admissions in this county for flu. So, we need to understand that the symptoms are not dissimilar, and it's happening at the same time. The symptoms appear after 2 to 14 days of exposure, which is considered the incubation period. So, it only been identified in humans since December, as reported earlier. And so we don't know if it's a new virus. We don't know how it will behave in a human host if it's never been in a human. What we're finding is it spread pretty easily, and we'll talk about that. And we know that there are some distinctions happening within Wuhan and where the intensity was highest related to transmissibility, and then certainly concerns about fatality rates, case fatality ratios that have emerged. We're still learning about this. We know that it can cause severe respiratory illness, particularly in people who are older, people who have compromised immune systems, people who may have limited or reduced lung function, people who are immune suppressed. When we saw H1N1 occur in 2009-10, we saw a number of pregnant women that were exposed and became infected. Excuse me, unfortunately, also children. We're seeing this trend, less kids, a small number of kids trend toward the older and those that may have a number of chronic challenges. So we don't know exactly how this will go. At this time, we don't have a vaccine. The earliest predictions from Dr. Fauci from the National Institute of Health, who is the sort of preeminent authority, is that it should be between 12 and 16 months when we'll have a vaccine. So we are going to be dealing with, and I'll talk about this, there aren't currently treatments, but we're going to be dealing with what we call non-pharmaceutical interventions to try and mitigate the situation until such time as we have a vaccine. Person-to-person distance in terms of spread is about 6 feet for respiratory droplets. We're talking about coughing and respiratory transmission as a primary route of exposure. People coughing, sneezing, not dissimilar to flu. Spread on surfaces and objects, and we'll talk a bit about that more. And thought to people potentially could be when they're most symptomatic, when they're sickest. We believe they're most infectious, but there's been a lot of reports about the potential for transmission from people that are not exhibiting symptoms. So there's something called R0, is basically the reproductivity of this disease, the ability to spread from person to person. So we know that for influenza, for every person that gets flu, 1 to 2 other people may get the flu. We know from measles that for every case of measles, 12 to 18 people could get measles. You could leave a room where someone who was fulminating with measles was, and our infectious disease docs can talk about this. There's still risk for hours afterwards for exposure to measles when you leave a room. It's highly infectious. SARS, sudden acute respiratory syndrome, 2 to 4 people, and right now COVID-19 is in the range of 2 to 3 people per individual that's infected. That's important to understand in terms of how we think about transmissibility and communicability out in the world. In terms of fatality rates, this is an evolving number. We know influenza is about 0.1%. I've now seen reports in the literature of for COVID-19 of anywhere from 0.5% to the 1.4% number. This is a New England Journal of Medicine number from a few days ago. This is an evolving context. We know that there's a question about how many cases there actually were in China. We've seen numbers as high as 90,000. 3,000 fatalities in total of what we've seen, certainly at this point, in the neighborhood of that number worldwide. It's a constantly changing number. So what we don't know is how many cases perhaps that didn't have symptoms were also cases. So we don't know what the denominator is necessarily. So there's great discussion about what the actual case fatality rate is and what it may be in countries, other countries outside of this area of high intensity. So we'll have to continue to watch the literature. A lot of this work has been reported on case activity that's occurred in China as the science emerges in the wake of what they've dealt with. We are seeing a reduction in new reports of cases in China, which is very promising for them. Most of the new reports, frankly, of new cases are occurring outside of China, elsewhere in the world. So we talked about flu. Anywhere between 32 and 45 million people get infected with flu, just to give you some sense of things. 14 million to 21 million medical visits, 300,000 to 560,000 hospitalizations, and between 18 and 46,000 deaths. So flu is nothing to fool with, and still is something we need to be concerned about and understand the symptoms are not dissimilar to what we know about the coronavirus. So in terms of risk assessment, these novel virus infections are always a public health concern because, again, we have a virus that's never been in a human host. When it's now in a human host, we can't predict how it's going to behave if we haven't seen it yet. We know how flu behaves because we have many cycles and flu seasons to understand flu. We do see some shift and drift of flu viruses every year, but we have a pretty good understanding of the science. We know it's caused illness, and among some high-risk folks, we know that it can cause serious illness. We understand that there is person-to-person transmission. It appears to be pretty easily transmitted. And we know that now, we'll talk a bit about this, we're seeing cases and activity in California, Oregon, and most pronounced in Washington. Right now, you've been reading in the media concerns about perhaps transmission that may have been occurring for some time. Testing is ramping up, concerns about cases and fatalities associated with long-term care facilities. We also have concerns annually in flu with long-term care facilities and transmission among fragile people. We also see seasonally with flu schools closed. This year, I think we've had 5 or 6 schools closed because of flu to break that chain of transmission. So these are concerns that we have as we look at this new virus as it begins to spread across the United States. I think we can anticipate that it's highly likely that we will see cases in Greater Cleveland. It's highly likely that we'll see cases all over the country in time. It's a question of what we can do to try to mute the opportunity for this spread and what we're doing to begin to institute controls based on our situational awareness, what's happening in Ohio, how the virus is moving around the country, the intensity, the new data that emerges from the science about the virus as that becomes available. And we're going to continue to monitor that, working with our clinical partners. So we believe the public health threat is high associated with the United States globally of seeing cases, particularly for high-risk people. Again, 80% of cases are considered very mild. 20% of cases are considered more severe, and somewhere in the neighborhood of 14 cases are where we're really concerned about people that may need to seek medical attention, may need additional support for supportive oxygen and the like. We believe in the United States, The immediate risk here is limited to some areas where we're seeing these foci of clusters. We haven't seen any cases in Ohio, and we'll talk about that at this stage. But the situation, and I will reinforce this, is highly fluid. It's what we knew, what I read on Saturday was different than what I knew on Sunday and what we saw emerging on Monday. So we need to understand the fluidity of this, particularly in the age of social media. We've been spending a lot of time trying to deal with rumors about what risks are and what they aren't. And it wasn't like that 10 years ago with H1N1. And so we're constantly having to try to stay ahead of that. So we can expect more cases. We think that we'll continue to see person-to-person transmission. And at some point, we expect there would be widespread transmission in the United States. There have been questions about whether things get better in the summer, and we don't know the answer to that because it's a new virus, and we don't know how it behaves. So I think it's too early for us to understand that. So the state reports at the state level people that are being tested. They are called persons under investigation. We are tracking travelers, and if the travelers are not exhibiting any symptoms, they're not considered a person under investigation. They're just a person that's self-quarantined and out of abundance of caution. And so at this time, 7 people have been tested. They're negative. Those tests currently all must go to CDC. They're now standing up. CDC is now standing up the capacity for states to do their own testing. And at some point, we hope that there will be capacity for hospitals to do testing as well. And at this time, that's not the case. But that's all flowing from CDC to states and then eventually making it available to hospital systems widely. The numbers relative to the persons under investigation are changing on a daily basis as well. People are being evaluated. People are coming in on planes. People are showing up at emergency rooms in places with lower respiratory infections and are being evaluated because the criteria for testing is evolving in real time. So expect these numbers to change. And we will continue to work with the state as they report these changes out on a daily basis. We did show that 212 travelers to date are being monitored. Just to give you a sense of the volume, I saw a couple days ago that the state of California had 8,400 travelers that they were monitoring. So you get a sense of the scope of magnitude of this. On the coasts, particularly the West Coast, there's a lot more folks that are being monitored and coming in from areas of particular concern. So these numbers also are fluid. The numbers in the United States are somewhere around 100 these days. And imagine if I looked on the web, the numbers could change again depending on reports that are coming in from around the country. A total of 6 fatalities. Most of those fatalities are associated with the cluster I described in Seattle and associated with long-term care and a number of very fragile people. So this is a map that actually pulled from news that starts to give you a picture of these clusters as they're evolving around the United States. If we look at this tomorrow, I expect this map to change. I expect additional states to be included. And I lost count on the number of countries where we've isolated COVID-19. It's somewhere over 50. And I think it may even be much higher than that now, but we are at a pandemic status relative to this virus. It is important to note that H1N1 in 2009-10 was also considered a pandemic. At that time, the United States had over 60 million cases of H1N1 in the United States and somewhere around 12,500 fatalities associated with that virus. So we have folks here. I won't dig into the specifics here. We'll hear from Alex and certainly the Office of Emergency Services. I want to thank County Council and the County Administration for the support of the Office of Emergency Services. We have, in every emergency I've been involved with since I've been in public health for 30 years, we've worked hand in glove with emergency services, and we appreciate their expertise and the way they lean in on the response. And so it's critical for us in working together with the City of Cleveland, Department of Public Health, is that as we begin to message that we are all singing off the same sheet of music on the messages. And so I met yesterday with the City of Cleveland, and we're going to continue to work together. And as necessary, I'll certainly defer again to Office of Emergency Services around the details, but we're talking to lots of people in the community. There is guidance that's being developed on a regular basis from the state and from the feds in this fluid situation as we learn more. So guidance on a whole bunch of different settings. And we're working through those and posting those and making them available to the public and to specific groups and pushing them out. So what do we know about what works? Some of these you may sound like a broken record, or a public health broken record around hand washing. These data that you're going to see are tied back to sort of lessons learned from post H1N1 in 2009 and 2010. They look back at what worked. We know that hand washing works. 20 seconds. Wash your hands, sing happy birthday twice, and it will help to reduce a lot of burden of risk. We also know that good cough hygiene works. Coughing into your elbow will stop we used to hear say it, don't spray it when we were younger. You don't want those droplets to be distributed. Cough into your elbow. We also know that we want to continue our active surveillance, and what we do is if we have evidence of people as they're coming in, we're hearing about people that are traveling from the state, we immediately begin monitoring those folks for symptoms. They self-quarantine at home. We've had great collaboration and cooperation in that process. And so we monitor them, and then if someone were to become ill, we would then do contact tracing. We'd understand in advance who those folks had come into contact with prior to self-reporting to us. We'd be monitoring them for symptoms. They would also self-quarantine, and so it goes in sort of a ring. So we do that sort of assessment around contact tracing. And so that's pretty much the procedure. We also work very closely with our clinical partners where there's a need for testing. I would say on their behalf that we're going to do everything we can in public health to assure that worried well folks don't show up at emergency rooms because they have the sniffles. That doesn't help them take care of people who are very, very ill. And so we, in the past, in 2009 and 2010, actually worked with United Way 211 First Call for Help, and they assisted us to deal with worried well to try to take some of the burden off of this because people are concerned. So our job is to tell people not to be afraid, but to be ready and to be educated. And so that's what we've been doing for the last few weeks, and we're going to continue to do as this situation evolves. Non-pharmaceutical interventions. So these are, since we know it'll be 12 to 18 months before we actually have a vaccine, because there are a whole bunch of human trials that I think are set to begin in a few weeks. That'll have to be tiered up. It'll have to be then moved on to a series of larger and larger groups of people to assure that we don't have any unexpected outcomes associated with the vaccine. There's going to need to be liability issues and production and a range of things. So it's going to take a while. We're working now on the prevention mitigation side. So that's what we're going to focus on, and I'll talk a bit about what some of these things are as we move through these slides. So this is considered the sort of these mitigation options for pandemic influenza. You see a big purple curve. So left to its own devices, outbreaks could rise quickly depending on how communicable it is, and sort of peak, and then we begin to see this sort of bell-shaped process in an outbreak without any interventions to try and blunt that curve. What you see on the right with the brackets is what we try to do in terms of our mitigation strategies to try to reduce the height of that curve, try to mitigate and reduce exposures to try and blunt that curve and stretch it out and reduce the burden on the community ultimately. That's the role that we play working with our clinical partners and our emergency service partners together with public health, and also a range of entities in our community that can do things to help assist us in that process. So here we are. We're not seeing an outbreak. We don't have any cases confirmed by any testing here currently in Greater Cleveland. So we have this issue around people staying home when you're sick. We want people to do that during flu season. We think it's important. We see outbreaks occur of things like norovirus that is spread by fecal oral transmission. People don't wash their hands well. Or we see it among daycares in kids, where kids may go to a daycare and then expose other kids. It spreads very rapidly. And then they may go home, and then a family member goes home, a parent, and they're told by their boss that they need to come into work. And so even though their child's sick, so then they have to take their child to another daycare. And then you ignite a series of outbreaks moving through the community where daycares, you sort of have a hopscotching effect because mom can't stay home to take care of the kid because she's not given the sick time to do it. If you're sick, we believe people should be given the time to stay home and not be part of the solution and not be forced to have to go to work and then inadvertently potentially exacerbate a situation. Coughing and sneezing, working specifically around the idea of how you're washing hands and then throwing away. If you're going to cough, cover it up if you can, if you have a tissue. You're in a pinch, you've got your elbow. We'll also talk about hand washing. If you go in and you wash your hands after 20 seconds, you wet them off, you dry with a towel, use that towel to open the door. I think that's an important thing to think about. Hand hygiene. We also know that alcohol-based sanitizers, and I think there'll be more on that in a moment. We have Dr. Watts has come bearing gifts, alcohol hand sanitizers. We also know that frequently cleaning surfaces is in the literature is proven. Cleaning surfaces, cleaning door handles, doorknobs, common areas where people work in work environments, shared computer terminals, rails. Constant cleaning can help to reduce that viral load on those surfaces. And also we think giving people things that they can act upon helps with resilience. It gives them some things that they can do and be part of the problem, or reducing the problem, I should say. So we talked about staying home when you're sick and making sure you keep some distance when you're sick, and avoiding face-to-face contact. When things got very bad in China, when it began to fulminate, they actually prohibited in China people eating face-to-face because it had fulminated, and they were concerned about that. They limited the space between people in workstations. They limited the number of people that would ride an elevator together. These were very potentially disruptive things that they did, but they did it to try to reduce transmission because they were seeing such a high intensity of cases. Talking to your healthcare provider is really important about your risk, particularly those with these chronic illnesses, and you'll hear more about that. And here's a big important one for many reasons. If you're healthy, you don't need a face mask. We don't want you going on the internet, anyone in the community buying face masks. The folks in the hospitals need the face masks, protect the workers, to also put on people who are ill to prevent exposure to the workers, for EMS that may be involved in transport. These are the folks that need masks. You also have to be fit tested if you're going to wear what we call an N95 respirator, which stops 95% of particulate material of a certain size from getting and exposing you, getting through the mask. And so if you're not being fit tested and you buy an N95 mask on the internet, you're really not protecting yourself. You have to be fit tested. We've been talking about that a lot lately. And also, we know that if you have staying home when a household member is sick with respiratory diseases, if you're told to do so, if we're concerned that the patient individual or the person we're monitoring may be at risk and is being monitored for coronavirus, then we may be concerned about an exposure having taken place between household contact, which is what happened in Chicago in particular, where we saw husband and wife. So we know there are differences in some terminology here around separation and confinement. Isolation is for people who are sick, and quarantine is for people who are exposed but are not sick. And they're being quarantined during that period of time to see if they exhibit symptoms. That's a way of preventing community transmission. It's done, and Metro does this with tuberculosis, a whole range of infectious diseases. It's common sort of shoe leather public health. So I'm getting into some things that are important to understand. And before I talk about these, I want to relate back a story about something that happened in 2009 and 2010. There was, at the time, some will remember, there was something called a remote area medical effort called RAM that was set to happen at the county fairgrounds. And it was designed where it moved around the country. They recruited volunteers from the clinical community to provide free medical care to people, evaluations, glasses. They would have people who needed to have their teeth removed. They would provide a whole range of clinical supportive care to people that did not have insurance. And in the process, it was happening during the middle of the H1N1 outbreak when a lot of sick people would have showed up en masse to the fairgrounds, and the decision working with the state health department was to postpone that event. It was not done casually, but hindsight, it was clearly the right thing to do. And so what I want to talk about is it's all about context. Are we seeing local cases? Are we seeing community transmission? in Ohio? Are we seeing it locally? Are we seeing it in the region to make decisions about these non-pharmaceutical interventions that we have to consider employing if indeed we start seeing local activity? So these involve, and if you watch what's happening in Washington and other places, temporary closures or dismissals related to schools, social distancing and messaging around workspaces, as I said, to prevent that person-to-person transmission, telework, remote work options, modifying, postponing, or canceling these mass gatherings. These are things that are done. We know they can be very disruptive, but you do those based on understanding the situational awareness on the ground in your community, in areas around you, in consultation with the state health department to try to break that chain of transmission. We know it's happening in other countries right now where we've seen the travel restrictions rise. Italy, happening in Iran, happening in Japan, and I'm sure many other places, making decisions on ways to reduce this person-to-person transmission. So we have to play the cards that we are dealt, and we'll make decisions collectively on how to deal with these challenges. This is meant to tell you we're putting lots of messages out and lots of infographics for people to understand cough etiquette, to understand things that they can do to be part of the solution. We talked about surfaces. Here's a few more: countertops, tabletops, bathroom fixtures, tablets, bedside tables. My mother is in Florida on the way back with my father, and she has more Clorox wipes than I think one person should have, perhaps. But she uses them to wipe the buckle and the seatbelt on the airplane, to wipe down the rails, to wipe down that sort of net bag that people use to grab the magazines. The idea is to begin to think about things that you can do yourself to reduce that exposure for touch services and using household cleaning supplies and the like. We talked about face masks, not recommended that people use them. Healthcare professionals. I think I've covered pretty much on face masks, everything that I need to take care of there. We do lots of things in public health. Often it's invisible. I say that we're sort of like a good defensive back on the football field. You don't hear our name called on the PA. We're trying to prevent things from happening. If we're doing a good job covering our receiver, you never know that we're out there often in disease prevention. So we are busy at work and have been for a month responding and getting messages out, tracking people, tracking cases, working with our hospital systems to decide with the state health department whether people need to be tested. It's happening now. It's going to continue to happen because it's important to know that we are in the early stages of this process. This is a marathon. It's not a sprint, and we're still in the very early stages of this. It's important that we emphasize it. So here are some of the key messages. I'm getting close to wrapping up, and then I'm happy to take questions and then defer any particular clinical questions to our eminent physicians that are present. It's changing rapidly. We'll know something new tomorrow or even this evening that we didn't know now to present to you, and we will keep you posted. More cases will occur. We need to continue the public health response to detect, to test, isolate, contact trace. This is what we're going to continue to do. The CDC is constantly putting out guidance that they're updating, and we're making that available, pushing it out to the public, working with our emergency services partners. People need to take the opportunity to institute some of these controls in their own hands around good hygiene, around staying home when you're sick, washing hands, covering your cough. These are things that work. They are not just things that your grandmother told you to do. There's a reason they work. And we want people to be ready and not be afraid. And also to understand about where reliable sources of information are. There's a lot on the internet. There's a lot spinning in social media. Go to your health department. Go to your hospital. Go to CDC. Go to the state health department. These are sources of reliable, trusted information, and that's where you should go. And don't forget about flu. You can still get your flu shot. And also, if you do have the flu, talk to your doctor about antiviral medications. If you take them early in the course of the illness, they can be a big help at reducing the scope of your illness. So we'll continue working with CDC and the state and our partners locally. and we're going to continue to update our social media and our website. We have some resources for you and available. We're working with EMS. We're working with schools on guidance. As I said, there's been some schools that have closed from flu already this season, a number of schools. Businesses and employers, we're beginning to receive calls about what they should do, and we're in communication with them on the best information we have available about guidance as the situation evolves. So with that, I'll pause, Mr. Chairman and committee, and ask if there are any questions.
Thank you, Mr. Allen. Questions? Mr. President?
Just wanted to ask in general, is somebody going to speak to a little more to the details around testing? I mean, you touched on it. Maybe you can answer this yourself. There's, as you know, there's been reports around the testing issue.
Yes.
And could you help us understand how that's rolling out here in the local community or in Ohio or in the county in particular?
So I will talk about what I know. If our physician partners have additional information, here's what we know, is that the state, there have been some challenges at the national level in rolling out the testing strategy. There are a number of what they call reagents that they've had some challenges with in trying to develop a test that is portable, that can be used and ramped up, that they feel is reliable to move around the country. That's been an ongoing challenge, and I think for CDC in particular, it's been a burr under their saddle trying to sort of work through that process. Not testing can create challenges on how you focus for obvious reasons, how you focus your efforts in terms of focusing your control. At this stage, the state is working toward having that capacity. They want to start with the states first, and the goal is certainly to have hospital systems. All hospital systems have point-of-care testing as determined, as indicated by clinical evaluation. Anything else, Dr. Ray, you would add?
So I would say
you have to go.
the testing piece of this becomes ever more important when community transmission is sustained.
They're taping it, so, yeah.
Sorry. When community transmission is sustained. So early on in the course of the outbreak, we were hinging case discovery upon history of travel to China, and then the number of countries, as Terry mentioned, is greater than 50 now. So the symptoms of COVID-19 are nonspecific. They include fever, cough, shortness of breath, and those can be caused by any number of illnesses, infectious or otherwise. So early on, we were searching for a case to contain, and we were hinging that upon a travel history within a pertinent incubation window of time. Now it's become clear that community transmission person to person is occurring, and the patients therefore don't have a readily identifiable risk factor, but they do have an infectious illness.
For a follow-up, Mr. Chair. Sure. So if I'm understanding this, help me. Because of the nature of this, it's not clear exactly how to test yet. As far as I know, Metro is sort of at the forefront of infectious disease business in this state, I believe. So, are you able just flat out? Do you have the ability yet to test people for this virus? I'm just trying to understand.
So I think one thing to put this into context, there are many different viruses that all circulate at the same time of the year along with influenza. So while we can detect many of those lower respiratory tract infections, the novel coronavirus it's new to humans. Mm-hmm. And so being a new pathogen with its own set of genes requires a specific test, and that takes time to develop. So there are concerns around biosafety as well for the laboratories. What I'm hoping is that the private sector steps up with manufacturing of tests, and that we are able to purchase or partner or otherwise, it is a difficult thing to isolate and consider a diagnosis when the
So from what I understand, you're saying no. And so the question is, I understand that, I get it. I mean, I'm trying to understand it. So because we're in this situation that we're in with the testing not being available, what in the meantime do you do? How do you approach this without the ability to test?
So we're
Is it a
very
matter of
careful.
elimination, that if you test for a flu or you test for something else and they don't have, I mean, would it be, I'm just in my own layman's way of looking at it, elimination would be part of the way you would approach it?
That's an excellent point. So yes, we will test because influenza is still causing disease actively in our community. Now, and if a patient were to test positive, we believe that it's a sole diagnosis, meaning influenza is causing the patient's illness. But infectious diseases is not always so clean. So sometimes patients have two types of infection. So to answer your question, how we proceed now is we take a very careful history. So if someone were to come in with a lower respiratory tract infection with fever, we would ask about relatives who are ill, relatives who have traveled, relatives who are healthcare workers and therefore may have been exposed. We would do our best with our partners in public health to ascertain and determine if the patient before me is one of low risk, medium risk, or high risk. And because there's no specific treatment for this viral infection, our course of clinical care will not differ based upon the supportive care is what we have to treat the patient.
So you treat it just as a flu?
So it's important because influenza, there are medications to treat influenza which can mitigate the morbidity and mortality of influenza infection. There's a vaccine, and we know it's a underutilized vaccine. Plus, all of us in this room have had influenza multiple times in our lives, whether you know it or not, and you have some natural formed antibodies to protect us. The challenge with this virus is that none of us in this room have protective antibodies because we've not seen anything similar enough to this to generate a protective antibody response.
Gotcha. Thank you.
Okay,
You're welcome.
Here's what I want to do, because I think this is going to all round back to the doctors. Let's get through Alex's presentation, then we'll bring the doctors up, because I think that's where the rubber is going to meet the road here. Thank you, Mr. Allen.
Thank you.
Good afternoon. Thank you for having me here to talk a little bit about what we've done to this point and what we're going to move forward on. So there's really 3 points that we're going to talk about that I'm going to present on. And one is what we've done coordination-wise to this point. The next is where we're looking at a contingency planning standpoint. And then the third is more of a legal question that Nora and the law director, Mr. Hu, talked about yesterday, of continuity of government and how we legislate and how we pass things if it should spread, very widespread. As Mr. Allen said, we started on we, as in Department of Public Safety and Office of Emergency Management, started coordination January 26th with our partners from the Board of Health, the Cleveland Department of Health, Center for Health Affairs, which helps coordinate hospital affairs, as well as both emergency management offices. This group involves daily emails, daily information sharing, and it also, as Terry mentioned, has 2 weekly situation reports, or as we call them, sit reps. This pushes out information, it pushes out tactics, it pushes out known techniques to roughly 325 people now. This pushes it out to police chiefs, fire chiefs, mayors, Center for Health Affairs, our 911 centers, our community partners that may staff the Emergency Operations Center like the American Red Cross, and other partners throughout the county and the region. We continue to do that, and we'll continue to do that. There's been 11 of those so far. We've also, on an internal side, increased communications to employees, working with the Department of Communication. We have pushed out information, and you'll see it in the very near future in bathrooms and in other public places about some of the techniques that Mr. Allen talked about coughing to your elbow, washing your hands correctly, some of these common mitigation techniques. We've also developed a central kind of portal off of MyHR to where links, messaging, updates, and tips can be put to where, as you put in your time in, it's very evident, it's very apparent where you can go quickly. We've worked with the Department of Public Works and Director Mike Dever to talk about increasing the cleaning routine, increasing the frequency of hotspots where we talked about elevators, bathroom door handles, things of that effect where there's high frequency usage, as well as having the availability of hand sanitizer or these Clorox wipes where we're able to disinfect. We talked with the Department of Human Resources and Holly Woods, who's currently reviewing the telecommuting policy for the county, as in the handbook, I think section 609, which outlines telecommuting and allows for the ability for up to 90 days, I believe, at the discretion, and whether that's relevant for this if it were to escalate and we were looking at social distancing techniques. We have also built in contingency plans to increase operations, whether there was a person under investigation. Mr. Allen spoke about whether there were confirmed cases, which could lead to enhanced coordination needs through something like a joint information center, where public information officers come together, share correct information, and have joint statements, as well as the actual activation of the Emergency Operations Center to where we have our first responders, as well as our healthcare providers working hand in hand in joint effort in day-to-day operations. With that, those are some of the things that have gone on in the last month. As Terry said, there are no confirmed cases here, but we're also going to work towards planning should this spiral, should this get worse, should we start to talk about other things. The first point of that is the continuity of operations planning, or COOPs, as you'll hear them called. COOPs in the most basic function are what are your critical functions, whether it's mandated by law or what you have to provide. What do you need to do them, whether it be computers, IT, who needs to do them? What are your vital records, and who's in charge? Traditionally, these plans are done in the sense of natural disasters like tornadoes or hurricanes, where you're relocating buildings. This public health, the infectious disease, provides a different aspect that we need to look at, that we're going to look at, and we are. We also have to review what our ability to provide, if we have all of our facilities, and we have a reduced workforce, what we can do and how we can plan for that. Traditionally, this annual review is done in an April-May timeframe. We're pushing that up. We have 3 planning workshops to bring in these COOP managers in March. Those are 16th, 19th, and 23rd. They'll be held at the Emergency Operations Center. And we've also prioritized the Department of IT, Department of HR, Fiscal, and the sheriffs to pull those aside and sit down with them beforehand to walk through these plans to make sure they're where they need to be because of how important they are. We're also working with non-executive agencies. We met with the Juvenile Detention Center this morning, Office of Emergency Management did, and we'll meet with Mark Griffin, the Inspector General's office, this afternoon to build these continuity of operations plans out. So during this process, and we started to talk about the operational side of how we do what we do, we also started to look at continuity of government, which in its simplest form is how do we provide governance, how do we pass laws, how do we authorize purchasing at this point if there's a prolonged period to where social distancing is recommended, if there are members of this body where we can't have a quorum, how do we continue to move forward? In that, the initial research, it shows, or not research, but review, shows the ability under Section 501.08 with the emergency contracting, where you can, for an emergency event, purchase up to $500,000 for that one event. We also had some questions from an emergency management safety side that we met with law, and we talked about what the ability was if social gatherings were discouraged if members of this group or Board of Control or other legislative bodies were unable to meet, or we were discouraged from bringing large groups of people together. One of those conversations led to the talk of telecommuting or teleconferencing. While we have processes in place to where telecommuting can work for the workforce, under the Ohio Open Meetings Act, and I'll let Nora or Greg talk a little bit if they want to go real in depth, it specifically says you cannot hold public meetings over a teleconference. So there's no wiggle room at the moment on any of that. So that's something we're going to continue to look into and continue to look at options if this were to grow, if we were unable for a long period of time to convene this group or to convene Board of Control or other groups that pass this legislation. The other piece to this is looking at more specifically defining what a declaration of emergency is in codified ordinance. There's some, in a very relative term, that when we declare an emergency, it provides us the ability to request a state for aid as well as reimbursement. But when you flip that switch, what does that mean from a procurement side? We have pretty well laid out in this point. But what does that mean from a temporary hiring if we have very specific duties that have to happen? Is there the ability to look at temporary hires without going through PRC or HR? Is there the ability to perform mission critical functions in a time of an emergency where normal processes can't? That's not as well defined as I think it could be. That's something that I think we should continue to look at from a legal side and work with this group on checks, balances, who has the authority, just to where it's more definitively in code and where we're all on the same playbook moving forward. With that, I just wanted to, that was kind of the overview of what I wanted to talk about and to present to you guys what we're doing, what we're going to be doing, regardless of whether there's zero, if it stays at 0 cases. This is still an exercise that has enormous value for us because we don't know what the next emergency will be, and these continuity of operations plans and continuity of government are applicable, whether it's a terrorist event, whether it's infectious disease, or whether it's a tornado. So they have huge value. With that, I'll answer any questions that you may have.
Okay, Alex. That seems more directed to us. And what I would like to do, the committee's understanding of this also, is that within 2 weeks, the next 2 weeks, we'll have another meeting. We'll discuss situations with our public buildings, our jail, your further input as to what you think we need to do. I'll give you a couple weeks to get up and running as to where we should be heading. We could deal with the legal side of that through you and Brandy and the new chief of safety. But what I want to do is bring the doctors up. If you could kind of come up here and put this together for us, and if anybody, as you're going through, if anybody has questions, let me know. We'll jump right in there because I think what you have to offer is what we're really after right now. And Dr. Watts.
Well, we're happy to help in any way we can. So I'm Dr. Brooke Watts. I'm the Chief Quality and Experience Officer for Metro Health. I am not an infectious disease doctor. I'm a hospitalist. But part of what I get to do is help to translate what's going on for our patients. So my role today is really to make sure you know what we're telling our patients in our community and help you to communicate that to your folks so we really are on the same page. But I brought with me, I will honestly say, I believe to be the city's expert on infectious disease and emerging diseases, Dr. Amy Ray, who has many years of expertise in previous outbreaks as well as the current one. So the 3 things, quickly, that you need to remember. Number 1 is that we have a really good partners. So I know you know what Terry presented today is, from our perspective, exactly what you need to hear. And this is really important because we know our community is getting a lot of inaccurate and sometimes dangerous information. Someone who should have known better recently, in the last week, asked me if I thought giving Diet Mountain Dew to her kids would help because she'd read this somewhere, right? This is the age of social media. Number one is we need to keep pointing our community back to reliable sources of information. And the kinds of things that are coming out from our health department, the kinds of things that are coming out from the CDC are really good. There's some gaps they need to address, and your point about the testing is very clear. But the content that's coming out is important. So number one is reliable information. Number two, yes, you need to wash your hands. No, you don't need a mask, okay? Everybody's got this one. It's important because as Terry, and I brought a little prop just so you could see what we're talking about. So there's two kinds of masks. These are surgical masks. This is the one that the little Dr. Axton made the point, the little smiley face is wearing on your phone right now. So are these made to keep things in or to keep things out? Keep things in, right? This is what the surgeon wears when they're operating on you and you don't want anything dropping into the OR. So this keeps things in, it keeps droplets in. It doesn't keep the bugs out, okay? So these special masks, these are the ones that we wear to keep ourselves safe as healthcare providers when someone's sick. These are called the N95 masks that you've heard about. These should be about $1 a mask. And right now they're going for $20 a mask on eBay, okay? The community does not need these masks. Capitalism. And we ask, truthfully, that people stay away from buying these because we're going to need them to take care of folks, okay? The other important thing about these masks is they do have to be fitted to your face. You have to know the right size. You have to know how to use it. And if you don't know how to do that, there's risk with wearing the mask. We know that people touch their face a whole lot more, and it actually may increase your chances of getting an infection if you're wearing a mask and don't know how to do it. Best thing is not to touch anything up there, right? So do wash your hands. I have hand sanitizer for you. You don't need a mask. And the last thing is just don't forget about the flu. Right now, flu is still very present in our community. We're still seeing a lot of hospitalizations, less than before. We've certainly seen deaths. I think we're all very aware of the 2 pediatric deaths that we've had in this area this year. It is still much more common for folks to have the flu, obviously, than this. Yes, ma'am.
To the chair, to the doctor, how do you know when you have the flu versus, I think that's where the community needs to know.
Yeah, unfortunately, as Dr. Ray said, and may speak more, the symptoms that we're talking about from viruses are very basic, right? Fever. So fever you'll see with coronavirus or COVID-19, which is this very specific coronavirus that we're talking about. Something for the community to be aware of as well is that coronaviruses in general are things that we've all had. There's lots of different coronaviruses, and they often cause the cold. So most of us have probably had a coronavirus. We just haven't had this one, okay? And we've seen sometimes when we do testing, to Mr. Brady's point, when we do the respiratory swab testing, we can see them come back positive for coronavirus. It's just not that one, right? But the symptoms, the cough, the fever, are very nonspecific. And again, that's part of why we need people to be aware of the flu and get vaccinated. Because if there's anything we can do as a community to lower the chances that we'll have sick people, or even sick people who might think they have COVID-19 when they really have the flu, that's going to help protect all of us, right? Going forward. It's tough.
Mr. Miller, unless it's specifically to this, I'd like the doctors to finish. Does this follow up?
I'll ask my questions later.
Okay, I think it'd be a little easier for the doctors.
Dr. Ray.
Yes, thank you. So as Dr. Watts very kindly said, I am an infectious diseases doctor, queen of pestilence generally, all things putrid. But seriously, this is my bread and butter are emerging infectious diseases, and this is kind of what I was born to do in terms of hospital and healthcare system preparedness, along with the community education piece. But I'm also a mom and a daughter with elderly parents, and so I have a big investment in our community, and to that end, I really am very vigilant, almost hyper-vigilant, about following the trends that were coming out of China and and watching the epidemiology of this, it really has taken a concerted amount of energy because the rapidity with which the data is appearing is unlike anything I've ever seen. So we've spoken a lot about basic protective measures today, and I would just echo that those are the same messages that we apply in a healthcare setting. It's the foundation of the prevention of infectious diseases. So this is a virus in which if I'm speaking with Dr. Watts and I'm coughing, she's within my 3 to 6 feet droplet distance. As I speak, cough, sneeze, droplets are actual droplets which could land on her mucous membranes. A direct exposure would be Dr. Watts and I together for more than 2 minutes. So this would be the time that we've been up here. If I were infected, I could infect Dr. Watts. So what we have in infectious disease prevention is how to interrupt this transmission. That's where the emphasis is at this moment. As I mentioned to your question earlier, this is a population at risk because we haven't seen this before. So Dr. Watts is susceptible, as am I. So to mitigate the risk, we need effective barriers. That is true in the community and that's true in healthcare. So why do we say, we all say it and you hear it, and I think that people think that we're just being, wash your hands, wash your hands. Why? The reason why is because hands deliver your health care. If she's my patient, it's my hands that are delivering health care. It's my hands that are caring for my children. It's my hands that inadvertently touch my eyes and face and mouth multiple times a day. Hands are very important mode of care delivery, food preparation, everything we do. The greatest risk reduction piece that you can do is clean your hands. So it's really not me being trite, it's me being real. So in healthcare, as the person, I'm the medical director for the Special Diseases Care Unit at Metro, which is an emerging infectious diseases unit, and the medical director for infection prevention. So we take the cornerstones of hand hygiene and appropriate patient identification, and we build on them. And why? Because unlike in the community, if I'm walking past Dr. Watts, that's a no-risk situation. But if I'm taking care of Dr. Watts and now she's infected, if I'm her bedside nurse or her physician, I'm going to be interacting many, many times with her, potentially for very lengthy amounts of time. So in the healthcare environment, what we recommend is appropriate use of personal protective equipment, which does include, these are actually, they're mask respirators. So the N95, 95 means that 95% of material is filtered by the mask. We would have our healthcare workers also gown, glove, and use a face shield or goggles to cover their eyes because, again, it's the mucous membranes that I'm concerned about. That we're concerned about with transmission. So we take that heightened level of protection for healthcare workers because we know from previous epidemics, SARS and MERS, Middle Eastern Respiratory Syndrome, that healthcare workers were very frequently infected. And that healthcare was actually the most common place a patient became infected. So we take enhanced measures, we train around this, we drill around this at Metro. Beyond the personal protective equipment, we have engineering controls in the hospital such that if I suspect that Dr. Watts is an infected patient, she is immediately given a mask to contain her secretions as she demonstrated, and then she's placed into a private room with air handling that circulates her air only to the outside, pulls air into her room, and not pushing air out of her room. So that is what we would consider an engineering control. So airborne isolation, basics of good care delivery, because at Metro we remain true to the mission, which is for years we've been taking care of infected patients, and that we plan to do that in a safe way, both for the patient, their family, the community, and our healthcare workers. And to that end, I just also want to say really quickly, a lot of hospital preparedness, a lot of emerging disease preparedness is in the inpatient. It's inpatient, hospital focused, and I know that we've already directed some of my staff to make site visits to our clinics that are off-site, where patients are coming for their diagnostic tests, just to make sure that the staff is being heard, their concerns are being addressed, that we have appropriate surgical mask, the yellow mask, and gloves and hand hygiene products, and some signage just to remind healthcare workers. The other big piece of what I do is educate. So I'm in front of as many groups of physicians and nurses and nurse practitioners who will have me, essentially. And that really, I feel, is my duty, because this is a new disease state. Pneumonia is not a new disease state, but the pneumonia secondary to this infection very much is. And so there are some clinical pearls, if you will, even though I've personally never seen a case, I've reviewed the cases and know some of the laboratory trends, some things that might be more subtle, to your point, Mr. President, about how does one make these diagnoses.
Just for a point of clarity, just make sure we're all on the same page, the kind of negative pressure isolation, what a hospital needs to care for a patient with coronavirus, is something that's universal. All hospitals in Cleveland have this capability. It's not unique to Metro. I know you know about our very specific unit, that it's some very specific criteria for emerging diseases. This coronavirus or COVID-19 does not require that level of care. So you could see these patients, in fact you will see, or you'll likely see, these patients in a variety of different hospitals and locations throughout Cleveland, just to make sure you understood. Thanks.
Okay, thank you. Mr. Miller.
Thank you. Mr. Chair, to the representatives, I've heard media reports saying that some people think that the incubation period is way longer than the standard 2 weeks. The 2 to 14-day time was referenced in the earlier presentation. How confident are we that we have a handle on what the incubation period is, and what's currently the best thinking on that?
So what the medical literature supports at this time, compiling all of the case series which have been published, is a window between 4 and 7 days. And that's been replicated in different studies from various sites. So the 2 to 14-day window is purposely broad. What is lesser known is how long a human after an infection would shed virus. But the incubation time, which is the time from exposure to the time to development of symptoms, is on average about 5.6 days.
Okay, and my second question is what's currently the treatment? When somebody arrives in the hospital and they're in that 20% group that has a severe case, how do we try to treat them, and does treatment do any good, or is it simply a matter of if the person is strong enough and healthy enough to survive, to fight it off, they recover?
So that's another excellent question, thank you. So the treatment is really supportive, and so as you say, allowing the human host to recover. So management of symptoms, such as management of a cough, control of fever, comfort of the patient, respiratory support in terms of whether or not someone needs oxygen or actually needs ventilatory support with mechanical ventilation. There are some ongoing drug trials in the United States that have just been announced in the last day or two. There has been one patient in the United States treated with an investigational drug. Remdesivir is the name of this drug, and it was distributed by CDC under investigational use. It is a medication that was developed to treat Ebola, but has never been FDA approved for Ebola, or has actually no FDA approval for any indication at this time. But importantly, I think just taking a step back, we need to, a patient who would present with a pneumonia to our hospital now would have an influenza test. They would have, if they're fevered, blood cultures, some other things to make sure that we're not missing influenza or missing a bacterial pneumonia in the setting of influenza. So typically, patients require hydration, probably antibiotics until it becomes obvious that the problem is not treated with antibiotics.
Regarding the current flu season in the United States, is it considered to be average, worse than average, or not as bad as average for this season?
So the current influenza season is considered moderate. It's average. It is not as severe as the 2017-18 season, but it is more severe than last year. This current influenza season was very unique in that influenza B circulated widely among communities and children starting at the end of October. We usually don't see influenza B until the end of the influenza season, which is in the spring. So the strain of influenza, which is circulating now and causing hospitalizations, is the same strain. It's the H1N1 2009 that is still circulating among our communities despite an excellent vaccine match for the last 10 years. So influenza has a way of lingering.
It's important, all the measures that we're talking about that that Terry reviewed related to coronavirus, I mean, these are exactly the same things we need to do for influenza. So maybe the good news or bad news from a virus is it's all the same stuff. So none of this is wasted effort in preparation. It will help us with flu to be more aware of how these things are transmitted and what steps we can take as a community to help reduce that.
Anything further, Mr.?
Not at this time. Thank you.
Doctors, if you could, and I don't know if there's connectivity of this, going back to Mr. Brady's question about testing. H1N1, were we up and running with testing back then, or did it take X amount of months to do that?
Amy lived through that, every instance of it.
Yes, so
this seems to be somewhat similar as far as...
So it's somewhat similar, but yes, when H1N1 happened, the sensitivity of the diagnostic tests was not ideal. So when the tests became widely available, the peak had already occurred. And so having said that, though, testing has come a long way. At 2009 influenza tests, we were looking at old school methodology of testing. Now for this virus and for influenza, we look at the specific genes. So we look at, it's a rapid molecular diagnostic test. So we're not having to tease it to culture and grow. We're just swabbing and looking to see if the genes of COVID-19 or the genes of influenza are present. So I think that is good news because there's a lot more experience in the last 10 years developing those types of tests. So now that the FDA has released some authorization for other manufacturers to ramp up test production, I'm very hopeful that we will have the necessary diagnostic testing soon.
So we're a little bit better now than we were then just because of the advancement in science and medical.
It took China 3 months to tell anyone that SARS was happening. So even from an epidemiologic public health perspective, this pathogen, this virus is, although the situation is very dynamic and does pose a threat, the science is keeping pace, I would say. Mm-hmm. And like I mentioned, it is advancing at the speed of light. It will help us tremendously to have a diagnostic test, because then we can appropriately diagnose and triage and protect and cohort patients who have the same infection.
Great.
Once we have the test, I know you'll expect this, but it's like what was seen in Washington. All of a sudden, you're going to have a whole bunch more cases, right? Just because you have the test. So prepare yourselves for once we do have the testing that you'll see huge spikes in numbers. It doesn't mean something different is happening. It just means we know about it.
Right. And what we're seeing now, probably, I would imagine H1N was the same way. You have senior living, rehab places, hospitals. Our obvious concern is public buildings and the jail are really hotbeds.
So
schools.
I just don't want to undersell influenza, the H1N1, because there was a really high morbidity and mortality among pregnant women and young people and children. COVID-19, the case fatality rate, so the risk of dying increases above the age of 60 to 70. Fewer than 1% of the cases have occurred in the age group 0 to 10. Another fewer than 1% of the cases have occurred age 10 to 19. So every year for seasonal influenza, epidemiologists think of a U-shaped curve. So if you think about age on a graph, the risk of death and dying and suffering is for the very young and the elderly. That's what we would consider a U-shaped curve. This is looking more like half of a U-shaped curve versus, quite frankly, in 2009, it was a W-shaped curve. So the very young, some healthy adults, including pregnant women, and the elderly.
Being 63 years old, you've made my day.
That's a spring chicken.
Hopefully. Any other questions? Yes, sir.
Thank you. Through the chair, thank you for coming out this afternoon. It's very important to get the facts out there because, like you said, in the age of social media, here's some crazy things out there. I mean, I haven't had Chinese food in like 2 weeks. So
this virus does not discriminate, let's be clear.
Okay. So as far as what we can do about it and getting information out there, does Metro Health have stuff out on a web page or a site, or is there somewhere that people can access this stuff and get easy information as to, what to do, wash the hands and, that sort of thing?
This is changing so fast that we really are thinking it's better to go to central sources. Right now, the state has stood up their own website. I think it's coronavirus.ohio.gov. They're doing a great job, and this has really become almost as a true full-time job because things are changing by the hour. They're also tightly linking with the CDC content. Having spent now everyday time with the CDC content, I must tell you they're doing a good job. They're updating as quick as they can. They've been very transparent with what they have, and I think the materials, from my perspective, is trying to be a patient advocate and a communicator. I think they're putting out really good, solid information for patients. So I think particularly because we're all changing so fast, it's important for us not to reinvent the wheel. Be consistent in our messaging. It is go to a reliable source, whether it's the state or the CDC for now. Wash your hands. You don't need a mask. And remember your flu. Take your flu. If we can just keep pushing that messaging for now, I think, as things sort of tail off, there'll be opportunities for other kinds of communications. But right now, I think that's the safest way to make sure we stay all on the same page.
Okay, appreciate that. Thank you.
Mr. Miller?
So, Mr. Chairman, a follow-up question. Since you said that we don't have the diagnostic test perfected yet, what are we currently testing for when we use the test kits that are being used at this time?
So in the city of Cleveland, there are no test kits at this time. So the test originated and was developed by the Centers for Disease Control and Prevention. So testing in this country at this time is driven by Atlanta. The CDC did distribute test kits to the state departments of health. There were, as Terry mentioned earlier, there were difficulties, and those test kits were not able to be utilized because they were not able to be validated as being accurate. So that has significantly slowed the testing capacity and has created a backlog at CDC Atlanta.
So are you saying that we currently don't have any valid testing devices in use in the United States?
No, I'm saying that the testing for COVID-19 or SARS-CoV-2 has been created by public health for public health purposes. And they have, until the FDA released the other manufacturers to pursue test development, and that was just the past weekend, just a couple of days ago. So it takes time for those products to become commercially available and distributed. So our testing has been limited to what the public health department can provide at a national level. And for that reason, and for reasons, frankly, that we haven't had any persons under investigation at Metro Health, we have not ordered a test to avoid further backlog in patient care.
I'm not clear on your answer. Do we have good and accurate test kits at the national level, or and they just haven't been distributed, or don't we even have test kits whose validity has been proven?
The test kits centrally are valid. They have excellent sensitivity, the ability to detect infection, and excellent ability to rule out the infection. But the distribution has not gone smoothly to the state level. So the test itself is an excellent test. It's the standard of care test. But the demand for the test is far outweighing the public health ability to perform the testing.
Understood. Thank you.
Anything further? Yes, ma'am.
Just a question, and thank you for being here. I learned a lot today. They call the flu season. I'm not sure why the flu comes different times of the year. So is there any evidence that this too has a season that we could see some relief come April, May, June, maybe the hot months of August, September?
So in temperate climates, influenza circulates every year. So, for example, at this time of the year, the World Health Organization is already looking to the Southern Hemisphere to plan what strains are being included in our vaccine for next year. So you can kind of set your clock that there will be some kind of influenza that happens next fall. These influenza viruses like colder temperatures, they particularly like dry air, and like clockwork, a bunch of viruses which cause respiratory symptoms in the upper and lower respiratory tract, they all have that in common. So what's not known is whether this particular beta coronavirus, it was just discovered in early January, so it's too soon to say if that will follow a pattern of seasonality. But the same time that influenza circulates, the common cold viruses are circulating, and that leads to a lot of misperception of, I got the flu shot and I got the flu. Well, you got the flu shot and you got a cold because colds are what's circulating. So there is we track it from a hospital standpoint and a public health standpoint. We track and trend pediatric deaths due to influenza, hospitalizations related to influenza, and how much testing our facilities are doing and what those results have looked like. It's something that I tell my staff in infection prevention, that influenza is a year-round topic. So there's a seasonal flu that we just talked about, and then there's this X factor of pandemic influenza. So in 2009, in the spring, there was a little tiny activity bump of flu that was unusual. And that was the start of H1N1. That was the first wave. And then the second wave, there was very little, but some steady activity through the summer. And the fall is when the major peak occurred, and it actually occurred in October, which is early for flu season. Typically, in an average flu year, just like this year, the peak activity is about January into early February.
You know, this is we're all hoping for the best, but we would be remiss if we did not plan for the worst with this, as regards to the season.
Thank you.
Okay. Anything further? Doctors, thank you very much. This has been great and informational. Dr. Ray, you're available for larger groups to,
I am.
and no pun intended, spread the word?
I am. I'm available. I'll make myself available.
Thank you.
I'd be happy to serve.
Thank you very much.
Thank you.
Does anyone have any questions for Mr. Pelham or Mr. Allen?
Mr. Chair.
Yes, sir.
Just very briefly, Mr. Pelham, as far as, I'll let you get up there. As far as the county's plan, contingency plan, are there any, is there anything in place for our homeless shelters or individuals who might feel that they have something and you don't want to go and spread things at a homeless shelter? I mean, is there anything in place like that?
At this point, I'd have to reach back with Mark and talk to the Board of Health. Offhand, I can't answer affirmative, but okay. I don't want that to be 100%.
Yeah, I just think that we should be proactive in that area in the event, so we don't have any issues in a setting like that. And I suppose that would probably be something similar in the jails that we'll be taking a look at as well. So large populations of people who really may or may not have a choice as to where to go sometimes. So
and we'll look into that.
Okay, I appreciate it.
And
Thank you.
We can add that to our broader discussion when it comes to our public buildings. And I won't bring you in 2 weeks, St. Patrick's Day, but maybe the Monday or the Wednesday after. We'll have to figure that out. But put you on notice that we're very interested in ramping this up and being prepared. Obviously, you're concerned about that. We wouldn't be here if we weren't. And I think what I got out of today was the flu is our enemy today, and this will probably be our enemy tomorrow or down the line. But we have to kind of concentrate on the flu right now, and the not to panic has been, I think, the message that I got, which is a good message to get. And if we can get that further out to the community, that would be great. So in a couple weeks, we'd have you back with a broader discussion on what we're doing internally. Give you that time to do it. I know you're working on that. I talked to Mr. Morales today. I know he's hard working on that. And again, our concern is especially the jail and the workers there, the attorneys that come in and out, and the people that come through the front door. Thank you very much.
Thank you.
And is there anything else? Thank you.